Welcome to Pathology Central Key Concepts. Today's video is on atherosclerosis. In this video, I will be describing the response of endothelium to injury, summarizing the steps involved in atheroma formation, and then discussing the clinical implications of atherosclerosis. But before we even begin, we have to start talking about the endothelium. Endothelial cells are modified squamous cells, and unlike the ones of the skin that are basically pretty much inert and are there for protection, the endothelium has a very dynamic interaction with its environment and responds to stimuli like cytokines or hemodynamic stress or lipid products will respond in a variety of ways, such as by expressing adhesion molecules, producing biologically active products like cytokines and chemokines, producing procoagulant and anticoagulant factors, as I discussed in the hemostasis videos. So the endothelium is a very dynamic cell type, and this is critical to our understanding of the pathogenesis of atherosclerosis. So the next thing we need to think about is the stereotypical vascular response to injury, okay? Because this too will be key to understanding atherosclerosis. So when you have injury to a vessel, perhaps due to endothelial cell dysfunction or loss, and I'll discuss endothelial cell dysfunction in a moment, what will happen is you will end up with smooth muscle cell recruitment and growth, as well as synthesis of extracellular matrix. And this is going to lead to intimal thickening. So let's take a look here at this image from the 11th edition of Robbins Kumar Basic Pathology. You can see here we have a vessel with the media, internal elastic lamina, and the intima. And when we have some sort of injury to the vessel, we're going to get recruitment of smooth muscle cells, either coming in from the media or smooth muscle precursors in the blood that are going to migrate to the intima and begin to proliferate. So we can see that visually here as these mitotic figures. In response to a variety of biological factors, we're going to have elaboration of extracellular matrix. Now, if this injury is a one-time acute event, then there can be resolution and healing. But if, as we see here, we have repeated injury, which is the case in atherosclerosis, we can end up with stenosis of small and medium blood vessels. So what is atherosclerosis? Well, I know that you're all familiar with this because this is a huge topic which has a significant contribution to morbidity and mortality worldwide, in particular in the Western world or for those who are adapting a Western lifestyle and Western diet. So atherosclerosis is basically defined as intimal lesions, and these lesions can be called atheromas or atheromatous or atherosclerotic plaques. And these impinge on the vascular lumen. So they may form just a small bump that disrupts the laminar flow, but they can also progress to become quite sizable, and they can cause chronic occlusion through gradual growth, or with rupture or superposition of a thrombus, they might end up with acute occlusion. And because atherosclerosis is so prevalent and because of these possible outcomes, it contributes to coronary, cerebral, and peripheral vascular disease and also plays a role in aneurysms, particularly in abdominal aortic aneurysms. And as I mentioned here, it causes about 50% of deaths in the Western world. Keeping in mind that Western world is linked to Western lifestyle and diet, and as we export our culture, we are seeing increases in atherosclerosis elsewhere. Now, there are a lot of risk factors for atherosclerosis. I've listed them here. They're covered quite well, and I think in a very straightforward fashion in the Robbins textbooks. So I encourage you to go there. We'll be talking a little bit more about hyperlipidemia as well as inflammation as we continue. So here is a stereotypical atheroma. This also comes from the 11th edition. And you can see here we have the media, internal elastic lamina. But here, instead of the endothelium overlying a narrow intima, we have this large necrotic center here, which is composed of cellular debris, foam cells, which we see here, extracellular lipid in the form of cholesterol crystals. And because there's necrosis, we will end up with dystrophic calcification. And this is part of what contributes to the hardening of the arteries that atherosclerosis actually means, sclerosis meaning hardening. Now, this necrotic center is bounded on its sides by a shoulder area, and there's an overlying fibrous cap, which you see here, which is primarily going to be composed of smooth muscle cells, collagen, elastin, proteoglycans. We can get some in the shoulder areas, and around here we can get some neovascularization. And we'll see inflammatory cells, macrophages, foam cells, lymphocytes throughout this atheroma. Now, that's just a cartoon. Let's take a look at the real deal. So this is just a really nice example, classic example of a coronary artery. And you can see here that the vessel lumen is much narrower than we would like to see in a healthy non-atherosclerotic coronary artery. I'd say here perhaps the diameter is about a half of what, or maybe a third of the normal vessel lumen. What you can appreciate here is that necrotic core. Even at low power, you can see these white spaces. These are cholesterol clefts. Don't worry, we'll be going on higher power soon. And this is a fibrous cap. So here it is overlying here. And as promised, here are some dark purple areas that are calcification. So these are areas of dystrophic calcification. Okay, so let's talk about the pathogenesis of atherosclerosis. And I'm going to need to take a couple of detours before we get to the whole story, because I want to be sure you understand the concepts. So atherosclerosis we think of as being a response to injury. So we have a chronic inflammatory and healing response in the arterial wall due to endothelial injury. So what is this endothelial injury, and how does it cause all of this? So what happens is when you have endothelial cell injury, you're going to get endothelial dysfunction. I'm going to digress for a little bit on endothelial dysfunction. So endothelial dysfunction is an alteration in the endothelial phenotype. So this is done by upregulation and downregulations of a variety of different genes. And what you end up with is an endothelial cell that is often pro-inflammatory and pro-thrombogenic. And it has a couple of other features as well. It tends to have increased permeability, and it tends to have increased leukocyte adhesion. Now, this is an image that comes from Robbins Pathologic Basis of Disease. I've clipped it down just to focus on the area of interest regarding endothelial dysfunction. So here we have our endothelium with our underlying intima, and we have some sort of injury that occurs to this. And I'll talk about what some of those injurious stimuli might be. As I mentioned, you're going to get increased endothelial permeability. And what this will allow is LDL from the blood to enter the intima. So obviously, if someone who has increased LDL, there's a greater chance it will enter. If you have someone who has a very good lipid profile, there won't be this LDL that's floating around in the serum. So LDL is able to enter the intima. There it's going to encounter are monocytes. So monocytes are now going to be able to adhere to the endothelium as part of this increased leukocyte adhesion. Once they adhere, they are going to transmigrate and enter the intima. And when they see this LDL, which is going to be oxidized because this is a pro-inflammatory area, right? So we'll have oxidized LDL. The macrophage is going to gobble that up, and in response to this is going to be elaborating cytokines as well as some reactive oxygen species. The lipid is going to be consumed and to form here a foamy macrophage. All right, so this is just an overview of endothelial dysfunction. So what are causes of endothelial dysfunction? There are a lot of them. So it can be bacterial infection, it can be toxins, and it can be a variety of different things. But the two I want us to focus on in the context of atherosclerosis are hemodynamic disturbances and hypercholesterolemia. So in the typical happy vessel where we have smooth laminar flow, it's not turbulent, the endothelium is going to respond to that by elaborating products that are protective against atherosclerosis. However, in areas where we have turbulent flow, these proteins will not be elaborated, and we're going to have a pro-atherogenic surface. And one way that we can recognize this is that while the surface of the aorta is very smooth, where we have the ostia, so where the vessels are coming off, like the superior mesenteric artery or the vertebral arteries, there's going to be some turbulence to that flow. And this is often where we see the earliest atheromatous changes in younger individuals. Now, another significant cause of endothelial dysfunction is hypercholesterolemia. And what we mean by this is this particular constellation of lipids where we have increased LDL cholesterol, decreased HDL cholesterol, and increased lipoprotein A. And this is covered as well in Robbins. So what happens when you have this? So we're going to have our LDL cholesterol entering the intima, as I showed earlier. And this is going to cause local oxygen-free radical production. These lipoproteins accumulate in the intima. They're going to be oxidized due to these reactive oxygen species. As they reach a certain threshold, we're going to have extracellular lipid in the form of cholesterol crystals. And all of this is this pro-inflammatory environment, which is going to cause the surrounding cells to elaborate growth factors, cytokines, chemokines, pro-inflammatory mediators. Okay, so now that we have this background, let's go again to how we think of the pathogenesis of atherosclerosis. So one thing to keep in mind is that this is not a stepwise progression. This is a chronic injury, and so this is all going on simultaneously. So we have that initial insult, that endothelial cell injury leading to endothelial dysfunction. As I mentioned, increased permeability, increased adhesion, and we can also get thrombosis because this dysfunctional endothelium is procoagulant. Now, as I discussed earlier, we're going to get lipoprotein accumulation in the vessel wall, either as oxidized LDL or cholesterol crystals. I showed you monocytes adhesing, then migrating into the intima and becoming macrophages and foam cells. Platelets will also adhere to this dysfunctional endothelium, creating a pro-thrombogenic milieu. Furthermore, these activated platelets and macrophages, as well as cells in the vascular walls, are going to begin recruiting those smooth muscle cells. All while this is going on, we're continuing to get more lipid coming in through this dysfunctional endothelium, resulting in extra and intracellular lipid accumulation. And we see this intracellular lipid in both smooth muscle cells and macrophages. All of this is creating this environment where we have smooth muscle cell proliferation, extracellular matrix production, recruitment of T cells. Okay, so with this last statement, recruitment of T cells, I need to take another small digression to talk about inflammation. Back when I was a little girl just studying pathology, we thought of atherosclerosis as being primarily related to just cholesterol and did not recognize the role of inflammation. But we now know that inflammation significantly contributes to the initiation, progression, and complications of atherosclerotic lesions. So here are some of the actors in that inflammatory cascade. We have macrophages, which I've discussed a little bit already. Cholesterol clefts will activate the inflammasome, which will result in release of interleukin-1, which I cover in the inflammatory mediators video. We also have the toxic oxygen species leading to LDL oxidation, and then the growth factors elaborated by these activated macrophages, which will stimulate smooth muscle cell proliferation. T cells, which have been recruited in by this inflammatory milieu, will elaborate their inflammatory cytokines, such as interferon gamma, thereby stimulating macrophages, endothelial cells, and smooth muscle cells. And then all involved in this, we're also going to have activated leukocytes and endothelial cells, which will be elaborating growth factors that will once more promote smooth muscle cell proliferation and matrix synthesis. With this, we are going to get thickening of that vessel wall, which is, as you'll recall, the classic response to injury of the vessel wall. So let's go through this in a figure, in a stepwise fashion, just so you can see how it all develops. This once more is from the 11th edition of Robbins Kumar Basic Pathology. So here we have a healthy vessel wall, probably from a young person, because we can see how clear and clean the endothelium is. And we have some sort of endothelial injury. That's what this little red squiggly arrow is denoting. And this can be hyperlipidemia, hypertension, smoking. These are all listed in those risk factors and discussed in Robbins. Now, in response to this endothelial injury, we're going to get endothelial dysfunction, leading, as we discussed, to increased permeability, leukocyte adhesion. Our monocytes are going to adhere to the endothelium and then migrate into the intima. We also are going to have platelets that are going to adhere to this dysfunctional endothelium. So what happens next? is that we have our activated macrophages here in the intima. We are beginning to accumulate lipids coming here through the activated permeable endothelium. So we have a little bit of lipid accumulation here, and we have smooth muscle recruitment. So this is either coming from the media or smooth muscle precursors in the blood migrating into this area as part of the response to injury. So the body is sensing injury in the vessel wall. This is its stereotypical response. Now, unless we at this point undergo a change in our diet and our lifestyle, we're going to get continued accumulation of lipids, and this area is going to continue to grow and fill up with lipid. You can see these very nice polka dot macrophages and smooth muscle cells that are engulfing lipid. At some point, we end up with foamy macrophages. And because this is a pro-inflammatory milieu, again, we have lymphocytes coming into this area. So this is going to provide for us the earliest gross finding in atherosclerosis, which is a fatty streak. So let's take a look. This is a beautiful image from James Cook University in Australia. It's hard to find a really nice image of the fatty streak because typically by the time most of us are in our even teens or young adulthood, and with today's diet, often even earlier than that, we have significant atherosclerosis. So frequently we will only see atheromas or fatty streaks in very young individuals who have died due to other circumstances. So here you can see a beautiful aorta, very, very smooth. You can imagine the blood moving in laminar flow very smoothly over this. And then we see here, this is that fatty streak, so a light yellow. And it's right here at an ostium. So as the blood is flowing, there's going to be some turbulence, and that is going to cause some dysfunction of that endothelial cell, and the endothelial cells here. Okay, but we do not stop here. We continue with our lifestyle and our diet, and the lipid continues to increase in this core here. And because of all this, now we've recruited smooth muscle cells here. We're laying down collagen. We have this fibrous cap, which is overlying now this atheroma. And we have more lymphocytes coming in, lipid debris, necrotic cells, foam cells. And this is the classic atheroma. So now let's take another look at the gross image of what we might see here. So this is an image from Robbins Pathology. You can see this is considered a mild example of atherosclerosis. So there are still areas with normal endothelium here, but you can appreciate these thickened areas here, these fibrous plaques. And one thing to keep in mind is, as you look at this, is that these fibrous plaques are now going to contribute to turbulent flow and non-laminar flow, thereby feeding back into endothelial dysfunction. So you can see why this is a hard process to stop once it gets started. Now we have here additional progression. So this would be considered severe atherosclerosis, though to be honest, I have seen atherosclerosis which is much, much worse even than this. But this would be considered severe. We can see here that as these fibrous plaques have enlarged, we can get thinning of that fibrous cap, where you can get therefore ulceration or erosion of that fibrous cap, exposing that very thrombogenic lipid core and necrotic debris to the bloodstream, so we can get a superimposed thrombus, or we can even get elaboration of this or ejection of this material into the bloodstream, which can cause emboli and downstream clotting. Okay, so we've covered sort of the development of atheromas. Let's now talk about the clinical consequences. And first, I'm going to bring you to where we are in a relatively safe and stable plaque, and then move on to what happens when things go awry. So once more, normal vessel. we move through our fatty streak to a fibrofatty plaque. So that would be, for example, the mild atherosclerosis in the previous image. But with continued progression, we are now going to get what we call an advanced or vulnerable plaque. So this is one where you can see here, you can imagine blood is going to flow very easily over this. There may be a little bit of turbulent flow, but here now we're starting to really impinge on this vessel wall, and this accumulation of necrosis and fatty debris is sticky and gooey and not stable. And we have, as it grows, we have thinning of this fibrous cap. Now here, I just want to show you, this would be something that I would consider to be just simply a fibrofatty plaque, perhaps a more advanced plaque. Now this patient was probably asymptomatic because we have sufficient vascular flow here. We typically only become symptomatic when we have 70 to 75% occlusion of the vessel. So perhaps this patient might have had early angina, stable angina, due to a decrease in oxygenation. But for the most part, this looks like a pretty stable atherosclerotic plaque. We have a relatively small atherosclerotic or atheromatous fatty core. We have a fairly thick fibrous cap, fairly robust, and so in the absence of anything that would cause any sort of progression, this would seem to me to be quite stable. Now let's take a look at higher magnification, because I promised this to you, so we can appreciate the features of an atheromatous plaque. So higher magnification shows you again this core with cholesterol clefts, little speckles of calcification from dystrophic calcification, and then again this fibrous cap. Now let's look on higher magnification still. So you can see here are these extracellular cholesterol clefts and all of this necrotic debris. So if you think about this as just sort of a squishy necrotic mess, it is this fibrous core, this fibrous cap, that is keeping this from being ejected into the blood vessel. And so what is going to help us to stay safe is the integrity of this fibrous cap, as well as factors associated with this necrotic core. So let's talk about the clinical consequences of atherosclerosis. What happens when things go bad? So as I mentioned, you can have rupture, ulceration, or erosion of that fibrous cap, which can lead to not only thrombosis, but also atheroembolism as that material is ejected into the bloodstream. You may, conversely, instead of there being ejection material out, you can have inpouring of blood, high pressure blood in an artery into that plaque. If the fibrous cap tears under high pressure, blood can enter and blow up that area like a balloon. And then finally, we can have aneurysm formation, and I'm going to address that at the end of this video. So let's return to our image. So we were, when last we left it, we were at an advanced vulnerable plaque that was still stable here, right? But if we have a variety of different factors that can happen, both intrinsic and extrinsic to this atheroma, then we can get our dangerous clinical consequences. Now, the first thing that could happen is simply that we don't have any of these things happen, but we continue with our Western diet and lifestyle, and then what will happen here is we'll get progressive plaque growth and a critical stenosis. So beyond that 70 to 75%, this patient is going to present to you with stable angina. But if we have something that that affects the integrity of this atheromatous plaque, that's when we get into things like rupture and hemorrhage. And what is important in this will be the plaque structure. So again, how thick is that fibrous plaque, or that fibrous cap? Does it have a lot of integrity to it, good smooth muscle cells, or does it have a lot of foam cells in it, and perhaps a lot of inflammation with elaboration of matrix metalloproteinases and collagenases and other factors that will destabilize that fibrous cap? The other thing is going to be, and another thing we need to think about is how big is this lipid core? Has it become a really big one full of lipid, which is therefore going to be more vulnerable? We have extrinsic factors as well. So blood pressure. So in someone who's hypertensive, you're going to have a lot more pressure, a lot more stress on this fibrous cap. And then things like how reactive are that individual's platelets. That's going to affect the ability to have thrombosis here. So, as I mentioned, we can get rupture of this fibrous cap, which could result in, as discussed before, we can get a downstream embolism. We can get a rapid occlusion by thrombus. This is very thrombogenic, and you can get a thrombus that's going to cause an acute occlusion. And we can, as this process continues, we can get wall weakening, which I'll cover when I discuss aneurysms, which will lead to our aneurysm and perhaps rupture. And then finally, as I mentioned, we can have hemorrhage into this atheroma, which will again lead to not to occlusion by thrombus, but to an acute occlusion as the blood pours in and this balloons out. So I'll just show you an example of that. Here is a coronary artery. You can see here the fibrous cap. Here is the necrotic core, and there's been a tear in this thin fibrous cap, and blood is starting to enter. And you can just imagine high pressure blood entering this, and these flaps just coming up like this, right? And then all of this really thrombogenic material starting a big thrombus. Boom, just like that, you'll have an acute occlusion. Okay, so now we're going to digress to discuss abdominal aortic aneurysms. Now, aneurysms in general are caused by an imbalance between extracellular matrix synthesis and degradation. And we can see a lot of different things that cause this. For example, if you have an autoimmune vasculitis, you will have inflammatory factors that are going to cause degradation of the extracellular matrix. But for this discussion, we're going to focus primarily on atherosclerosis in the abdominal aorta. So therefore, when we see this in the context of atherosclerosis, we end up with compromised structural integrity of the aortic media. And the strongest correlation is going to be with atherosclerosis, and I'll show you an image which will explain why this is, and also with smoking. So why is atherosclerosis so associated with aortic aneurysms in the abdomen? So this is an image that comes from Pathologic Basis of Disease that covers aneurysms in general, and it's a great figure which I have clipped and covered up so as not to distract you. But just to keep in mind, aneurysms can occur due to vessel weakening through aberrant TGF-beta signaling, so we see that in Marfan syndrome. You can also get aneurysms secondary to connective tissue degradation in hypertension. These are our vasa vasorum. So with hypertension, you can get stenosis of these vessels, which supply the outer media. And leading to necrosis. But what I want to focus on here is how atherosclerosis contributes to aortic abdominal aneurysms. So as you'll recall, the inner media really gets its oxygen supply by diffusion of oxygen. So in the perfect world, it comes across the endothelium, a very thin intima, and they are happily nourished. By contrast, of course, the outer media needs to be supplied by the vasa vasorum. If you have a big, thick atherosclerotic plaque, the oxygen simply cannot diffuse across this distance. So we're going to get ischemia of this internal media, which is then going to become weakened. And also we're going to see, because of this pro-inflammatory environment, we're going to have matrix metalloproteinases that will be elaborating factors that will begin really tearing apart the connective tissue. So we're going to get smooth muscle cell loss because of intermedia ischemia, which can lead to an aneurysm, and we also will have transmural inflammation with increased matrix metalloproteinase production and connective tissue degradation. What this is going to lead to, here's just a cartoon. There are two sort of types of true aneurysm we think of. One is a saccular aneurysm where you have an outpouching, and one is a fusiform where you have this general swelling. This is an image here which shows a large aortic aneurysm. Here's the superior mesenteric artery here, the iliac vessels here, and you can see there is this saccular aneurysm bulging out because of weakening in that vessel wall. I'm going to finish up with just a series of questions so that you can look at this, reflect on what you've learned in the last 30 minutes or so. I hope that this has been useful. And if the questions aren't apparent to you, go back and take another look. As always, I'd like to thank you for your time and attention. Please do put comments below and follow me on Twitter. So thank you very much.